1, 2,
And
Patients here.
female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, when you're driving down the highway and like your check engine light suddenly flips on, it's usually just a warning, right?
Right, yeah, like a sensor is slightly off.
Exactly. Or maybe the emissions are just a little out of balance. But the engine is still running. You have plenty of time to, pull over and figure it out.
Sure.
But what happens when that warning light is ignored or a massive internal failure occurs and suddenly the engine block itself actually catches fire?
Well, then you aren't just pulling over to check the oil anymore.
Right. You are in a high-stakes race against total catastrophic system failure.
And there is a massive difference between a system that is just struggling and a system that is, actively destroying itself.
Yeah.
Recognizing that exact moment a patient crosses that line, that's what separates a good clinician from an elite one.
Welcome to this deep dive into the high-stakes world of critical care respiratory emergencies. If you are joining us, you are an eager learner ready to step up and really think like an elite ICU intensivist. Our mission today, using the source material on acute respiratory failure and acute respiratory distress syndrome, is to aggressively apply the 80-20 rule.
So no fluff.
Zero fluff.
Oh.
We are focusing purely on the critical mechanisms, the early recognition, and the priority interventions that actually save lives and drive bedside decision-making.
Because we want to look at exactly what kills the patient first.
Right.
We need to understand not just what is happening on the monitors, but the underlying cellular and physiological chaos that's driving those numbers. So you can actually anticipate the crash before it happens.
Okay, so let's unpack this. The respiratory system at its core really only has one primary job, which is gas exchange.
Bringing oxygen in and getting carbon dioxide out.
Right. And when that fundamental gas exchange fails, every single organ in the body is put on a ticking clock.
Which brings us right into acute respiratory failure, or ARF.
Okay.
And the fundamental concept to grasp here is that ARF is a symptom. I mean, it is not a disease in and of itself.
Wait, really? It's just a symptom?
Yeah, it's the ultimate failure of oxygenation, ventilation, or both, caused by some underlying trigger.
Oh, I see.
And we generally break it into two physiological buckets based on what we see in the arterial blood gases. So first, you have hypoxemic failure.
Meaning low oxygen.
Exactly. This is where the PO2 drops below 60 millimeters of mercury. The lungs simply cannot get enough oxygen into the blood.
And the second bucket.
Second, you have hypercapnic failure, where the PaCO2 rises above 50, and crucially, this is important, it's accompanied by a pH less than 7.35.
So the hypercapnic side means they aren't blowing off the CO2, and it's tuning the blood like dangerously acidic.
Exactly.
So if we trace the pathophysiology step by step to see how a patient ends up in failure, we always start with a trigger, right?
Right. Say a severe pneumonia or a COPD exacerbation.
Okay, and that leads to a physical physiologic change, like the alveoli might fill with fluid or the airways clamp down and obstruct.
And the body immediately recognizes that gas exchange is failing. The brain realizes it's starving for oxygen or, drowning in carbon dioxide, so it initiates the compensation phase.
Which looks like what, clinically?
The sympathetic nervous system kicks into overdrive, the heart rate spikes to pump more blood, so you get tachycardia, and the respiratory rate shoots up to pull in more air to dyspnea.
Okay, but breathing that fast and that hard takes a massive amount of metabolic energy, right?
It does.
They're essentially running a marathon while lying in bed.
That's a perfect way to put it. And eventually they hit a wall. That is the decompensation phase.
Where they just get too tired.
Right. The respiratory muscles, the diaphragm, the intercostals, they just completely fatigue. They literally cannot sustain the work of breathing.
Wow.
So the clinical findings we see on the monitors, the severe hypoxia, the dangerous acidemia, those are the result of that muscular exhaustion and the shift to anaerobic metabolism.
Which starts pumping lactic acid into the bloodstream and killing cells.
Exactly.
I'm trying to picture the mechanisms of how that hypoxemia actually happens, because the sources talk about a few different ways. specifically highlighting the difference between a VQ mismatch and a true shunt.
Right, that's a huge distinction.
So if we think about oxygen traveling into the bloodstream, like cars trying to cross a bridge,
Yeah.
is a VQ mismatch kind of like a massive traffic jam?
Yeah, go on.
Like the bridge is open, but maybe there's construction or an accident, so the oxygen are just slowly crawling across.
Yes.
But a shunt is like the bridge being completely washed out, so oxygen literally cannot cross into the blood at all.
That is a highly accurate way to visualize it. In a healthy lung, ventilation, the air coming in and perfusion, the blood flowing past the alveoli are perfectly matched.
Okay.
That is your VQ ratio. So a mismatch, your traffic jam, happens when secretions or bronchospasms slow the air down. Think of like an asthma attack.
Air is still moving, just poorly.
Exactly. And because the pathway is still technically open, if you give that patient supplemental oxygen, you flood the available lanes with more O2, and their hypoxemia actually improves.
Makes sense. But a shunt is a completely different beast.
Oh, totally. A true capillary shunt happens when the alveoli are entirely filled with fluid, pus, or blood, like in a severe pneumonia.
The bridge is gone.
The bridge is totally gone. Blood continues to flow past those fluid-filled alveoli, but no gas exchange can physically occur because the air cannot reach the capillary membrane.
Ah, so that is why giving supplemental oxygen to a patient with a true shunt often does absolutely nothing.
Correct. You can turn the oxygen up to 100%, but it cannot cross that fluid barrier.
That distinction is huge when you're standing at the bedside trying to figure out why the oxygen saturation isn't budging.
It really is.
Which brings us to assessment. There is a massive clinical trap here regarding cyanosis, waiting for the patient to turn blue.
Oh, waiting for cyanosis is waiting way too long.
Why is that?
Physiologically, it takes about 5 grams per deciliter of deoxygenated hemoglobin circulating in the bloodstream for a blue tint to actually become visible in the skin or mucous membranes.
That sounds like a lot.
It is. By the time you accumulate that much deoxygenated blood, the cellular damage is already happening. Cyanosis is a very late and highly unreliable sign.
So if I'm walking into a room, what is the absolute earliest warning sign that my patient is slipping into respiratory failure?
Well, the brain is incredibly sensitive to even slight drops in oxygen, so the earliest clinical sign of hypoxemia is almost always a change in mental status.
Like they get confused.
Yeah, you will see restlessness, agitation, or sudden confusion. If a previously calm patient is suddenly thrashing around or pulling at their gown, do not assume they are just anxious about being in the hospital.
You assume it's the oxygen.
Assume their brain is actively starving for oxygen until you prove otherwise with an arterial blood gas.
Wow, that completely shifts how we approach the initial interventions.
It has to.
When we step up to assess and plan our actions, obviously, securing a patent airway and delivering oxygen is the immediate priority. But there's a nuance here with how much oxygen we give, especially for patients with a history of COPD.
Right. You want to provide the lowest possible fraction of inspired oxygen, the FiO2, that keeps their blood saturation above 90%.
Because of their baseline CO2.
Exactly. For chronic COPD patients, their baseline CO2 is already high, so their brains have switched to using low oxygen as their primary drive to breathe.
So if you flood them with 100% oxygen,
you can completely knock out that hypoxic drive, and they will simply stop breathing.
Okay, so we've managed the airway and dialed in the oxygen. Now we need to mobilize all the secretions causing that traffic jam.
Right, getting the junk out.
The sources mention a positioning strategy called good lung down. I want to explore the mechanics of this because it sounds simple, but the physiology is actually fascinating.
It really is. It all comes down to how gravity affects blood flow. Pulmonary perfusion is heavily gravity dependent. Blood naturally pools in the dependent areas of the lungs.
So the lowest parts.
Right. Let's say your patient has a massive right-sided pneumonia. That right lung is your washed-out bridge. You do not want blood flowing there because it can't pick up oxygen.
So what do you do?
By turning the patient onto their left side, putting the healthy, good lung down against the bed, gravity physically pulls the bulk of the pulmonary blood flow into the healthy left lung.
That is brilliant. You're using physics to force a better VQ match.
Exactly. And if positioning and oxygen aren't enough, we escalate to non-invasive positive pressure ventilation, like BiPAP, to physically push the airways open and decrease the work of breathing.
hoping to avoid full intubation.
Always a pull.
While managing the mechanical side, you are also heavily managing the pharmacological side.
Yeah, you are pushing bronchodilators like albuterol to force the airways open, administering diuretics if the failure is cardiogenic and the lungs are wet, and hanging antibiotics for infectious triggers.
And fluid management becomes an incredibly delicate tightrope, doesn't it?
Oh, completely. You need enough IV hydration to thin out thick, stubborn secretions so the patient can cough them up.
But
if you give even a little too much, the failing heart can't handle it, and the fluid backs up straight into the alveolar spaces, causing pulmonary edema.
that balancing act brings up a terrifying safety alert. Let's go back to that restless, agitated patient who is pulling at their lines because their brain is hypoxic.
The one we talked about earlier.
Right. The immediate instinct for a lot of people might be to ask the provider for a sedative to calm them down so they don't pull out their IVs.
Doing that without fixing the underlying hypoxemia is a lethal mistake.
Really?
Yes.
Mm-hmm.
The restlessness is a compensatory survival mechanism. They are agitated because their sympathetic nervous system is desperately trying to keep them alive.
Oh, wow.
If you push a sedative, you completely suppress their central respiratory drive. Their exhausted respiratory muscles will finally just relax, and they will go straight into full respiratory arrest.
Wow. You are essentially turning off their body's only remaining alarm system.
Exactly.
So, if we can't just sedate them, how do we know when they are truly deteriorating and about to crash? Like, what are the vital trends we should worry about?
The most dangerous trend is a sudden drop in the respiratory rate.
Wait, really? Not an increase?
Novice clinicians might look at a patient whose breathing has slowed from 35 breaths a minute down to 14 and think, oh good, they're finally calming down.
But it's actually the opposite.
It means their diaphragm and intercostal muscles have completely failed. They have nothing left.
Oh, man.
You will also start to see paradoxical breathing, where the chest and the abdomen are moving in opposite directions because the mechanics of the chest wall have uncoupled.
And listen to how they speak, too, right?
Yes. If a patient can only manage to gasp out two-word sentences, they're in the middle of crashing.
And when you see that sudden drop in respiratory rate or that paradoxical movement, this isn't a situation where you, send a casual message to the provider and wait for a callback.
No, not at all.
This is an immediate rapid response or code escalation. You are preparing to intubate right then and there.
That is the intensivist mindset. You constantly frame the clinical picture. The problem is failing gas exchange.
The immediate threat to life is brain damage and cardiac arrest from severe hypoxia and lactic acidosis.
Right. So you intervene with targeted oxygen, gravity-dependent positioning, and BiPAP, and you constantly reassess their mental status to see if the brain is getting what it needs.
So if we synthesize everything about acute respiratory failure, if we remember only 5 things, it boils down to recognizing that core inability to transfer gases.
Right. That's number 1.
Number 2, visually, your key assessment is looking for that restless, tachycardic patient sitting bolt upright in a tripod position, struggling to speak.
3, you know the greatest dangerous complication is that anaerobic shift causing cell death.
4, your priority nursing action is maintaining that airway and positioning the good lung down.
And 5, your most important treatment is supplemental O2 and fixing whatever underlying cause triggered the whole cascade.
And the pattern recognition here. If you see a sudden drop in respiratory rate in a previously tachypneic patient,
You immediately think severe muscle fatigue leading to respiratory arrest, and you prepare to secure the airway.
all right, let's transition to the deep water. We started with the check engine light. Now, the engine is fully engulfed in flames.
ARDS.
Right. If localized lung failure or systemic shock triggers a massive, uncontrolled inflammatory cascade, we cross the threshold into Acute Respiratory Distress Syndrome, or ARDS.
ARDS is one of the most terrifying conditions you will ever manage. It is an explosive, highly destructive complication with a mortality rate hovering around 35%.
That is incredibly high.
And the most fascinating and dangerous part is that the primary trigger isn't always inside the lungs.
Wait, it's not?
No, the most common cause is systemic sepsis, originating somewhere else in the body entirely.
Okay, let's break down the pathophysiology of how this engine fire actually starts. The source is divided into 3 phases: exudative, proliferative, and fibrotic. How does a systemic infection destroy the lungs?
So, the sepsis triggers a massive release of systemic inflammatory mediators. These mediators travel through the bloodstream and viciously attack the alveolar capillary membrane.
which does what to the capillaries?
This attack drastically increases capillary permeability. The blood vessels become incredibly leaky, and fluid, proteins, and blood cells just flood directly into the alveolar spaces.
So the lungs are essentially filling with fluid from the inside out.
Exactly.
But it gets worse, right? Because this toxic fluid damages the type 2 alveolar cells.
Yes, and the type 2 cells are critical because they produce surfactant.
That's the stuff that keeps them open.
Right. It's the soap-like substance that breaks surface tension and keeps the alveoli pocked open. When the type 2 cells die, surfactant production stops.
And without surfactant,
The alveoli immediately collapse upon themselves. Widespread atelectasis. As the fluid, the dead cells, and the proteins mix together inside these collapsed air sacs, they form a thick, dense layer called a hyaline membrane.
I'm trying to visualize this hyaline membrane. The sources make it sound incredibly tough.
Think of it like pouring wet concrete into a sponge and letting it dry.
Oh, wow.
Yeah, the hyaline membrane creates a physical barrier that is incredibly thick and non-compliant. Because of this, it creates refractory hypoxemia, which is the absolute hallmark of ARDS.
Refractory meaning it just doesn't respond to typical treatments.
Correct.
You can put this patient on 100% oxygen, but their oxygen saturations will continue to plummet because the oxygen physically cannot diffuse across that concrete-like hyaline membrane, and the alveoli are crushed flat anyway.
Exactly. Early on, your assessment might just pick up subtle, scattered crackles in the bases of the lungs. But as that membrane forms, you see severe dyspnea, and the chest x-ray will show a complete whiteout. The lungs, which should look black and filled with air on an x-ray, look completely solid and white. To quantify how severe the damage is, we use the PF ratio.
That's the PaO2 from the arterial blood gas divided by the FiO2, which is the percentage of oxygen they are breathing in.
Right. A normal, healthy person walking around has a PF ratio greater than 400. In ARDS, we categorize it by severity. Less than 300 is mild, less than 200 is moderate, and less than 100 is severe ARDS.
Because they have this refractory hypoxemia, these patients absolutely require mechanical ventilation.
They do.
But I want to pause here, because the ventilator strategies for ARDS present a massive physiological paradox.
They really do.
The gold standard of care is low tidal volume ventilation, giving very small breaths, about 4 to 8 milliliters per kilogram, along with PEEP, positive end expiratory pressure.
Right.
But wait, hold on. Earlier, we clearly established that retaining carbon dioxide is terrible and turns the blood dangerously acidic.
We did.
But if you give a patient a tiny low tidal volume breath, they aren't going to blow off enough CO2. You're saying in ARDS, we purposefully want the carbon dioxide to run high. That sounds completely counterintuitive.
It is entirely counterintuitive until you look at the mechanics of the ARDS lung. We call this strategy permissive hypercapnia, and it is a necessary, brilliant trade-off. Remember, the ARDS lung is full of that concrete-like hyaline membrane. It is incredibly stiff. If we were to force a normal, large volume of air into those stiff lungs, the pressure will literally shred and pop the few healthy, fragile alveoli that are left.
Ouch.
Yeah, that is called barotrauma and volley trauma.
So we intentionally deliver small breaths to protect the physical structure of the lung.
Exactly. We accept that the carbon dioxide levels will rise and the blood will become slightly acidic as long as the pH doesn't drop below 7.3.
Huh.
Protecting the lung tissue from being blown apart by the ventilator is the higher priority.
Okay, that makes sense. You're choosing the lesser of two evils.
Always.
And what about the PEEP setting? I'm trying to picture how PEEP works. Is it kind of like when you pinch the neck of a balloon so it doesn't deflate all the way?
Yeah.
Keeping a little bit of air inside so it's easier to blow back up on the next breath?
Yes, exactly. And the reason we do that is to prevent the walls of the alveoli from completely sticking together. PEEP leaves constant positive pressure in the airways at the end of expiration.
So it holds them open.
It essentially forces those collapsed, fluid-filled alveoli open and holds them there. But here's the catch.
There's always a catch.
When you crank up that PEEP to hold the lungs open, it causes massive secondary complications in the rest of the body, specifically the cardiovascular system.
Right, because the lungs and the heart are trapped in the same rigid box, the chest cavity.
When you increase intrathoracic pressure with high PEEP, that pressure physically squishes the heart and compresses the inferior vena cava.
Which carries blood back to the heart.
Right. When the vena cava is compressed, blood cannot return to the right side of the heart. You severely decrease venous return, which drops your preload.
And if the heart has no preload,
cardiac output tanks, and the patient's blood pressure drops through the floor.
So a life-saving respiratory intervention directly causes a massive hemodynamic crisis.
It does.
If the nurse increases the PEEP on the ventilator, they need to be staring at the arterial line monitor, expecting the mean arterial pressure to drop instantly.
Absolutely.
Yeah.
And beyond the hemodynamics, you are monitoring for barotrauma, causing a pneumothorax, a collapsed lung from too much pressure.
What is?
You are aggressively preventing ventilator-associated pneumonia by strictly adhering to the VAP bundle, which means keeping the head of the bed elevated and performing rigorous oral care with chlorhexidine. And you are watching the kidneys.
Right, the sources specifically note that ARDS patients frequently develop acute kidney injury, but they're too hemodynamically unstable for regular hemodialysis.
Regular rapid dialysis pulls fluid off the body entirely too fast. Their compressed hearts simply cannot handle the rapid volume shifts.
So what's the alternative?
When they need dialysis, we use continuous renal replacement therapy, or CRRT, which runs 24 hours a day and pulls fluid off at a slow, gentle trickle.
Let's talk about the physical procedures at the bedside. The hallmark intervention for severe ARDS is physically turning the patient over to lie on their stomach for up to 16 hours a day.
Yes, proning is huge.
Why does lying on their stomach make such a massive difference?
Look at the anatomy of the lungs. The vast majority of your alveolar surface area is located in the posterior or dorsal region of your chest.
The back.
Right. When a patient lies flat on their back, the weight of their own fluid-filled lungs and the weight of their heart literally crushes those posterior alveoli.
Oh, wow.
By flipping them onto their stomach, you completely relieve that weight. Blood flow naturally shifts to the anterior portion of the lungs, and you suddenly recruit a massive surface area of dorsal alveoli that can now participate in gas exchange.
That's incredible. And while they are prone, we have to manage their fluids. The golden rule in ARDS seems to be keeping the patient dry.
Yes. You must avoid aggressive IV fluid boluses. Remember, the systemic inflammation has made the pulmonary capillaries leak like a sieve.
Right, they're already full of fluid.
So if the blood pressure drops because of the PEEP and you try to fix it by pumping them full of 5V fluids, that fluid will just leak straight out of the vessels and into the alveolar spaces, drowning them even faster.
So you manage the low blood pressure with vasopressors, not massive fluid boluses.
Exactly.
Which brings us to one of the most serious safety alerts in critical care. The use of neuromuscular blocking agents, or NMBAs, paralytics.
This is critical.
We use them so the patient stops fighting the ventilator, which decreases their oxygen demand. But the sources highlight a nightmare scenario if these aren't used correctly.
This cannot be overstated. Paralytics do absolutely nothing to the brain.
Nothing at all.
NMBAs do not provide any sedation, and they do not relieve a single ounce of pain. They only paralyze skeletal muscle.
Oh my gosh.
If a nurse administers a paralytic without concurrently running heavy, continuous sedation and analgesia, that patient is completely awake.
That is horrifying.
They can feel the endotracheal tube in their throat. They can feel the pain of their disease, but they are trapped inside a paralyzed body, unable to move, unable to breathe on their own, and unable to even blink to ask for help. It is literal agonizing torture.
It really emphasizes why the nurse has to be so meticulously vigilant.
Yeah.
You always ensure deep sedation before paralyzing.
Oh.
If we look at the clinical picture of ARDS deteriorating, you're watching for that PF ratio to continue dropping despite throwing maximum oxygen and PEEP at them, or watching for their blood pressure to completely bottom out after event change.
Exactly. When you step back and look at the entire ARDS picture, the 5 things to remember, you're managing a critically ill, usually septic patient whose oxygen saturations continue to fall despite being on 100% oxygen via the vent.
That's your key assessment finding right there. Refractory hypoxemia and a whiteout chest x-ray.
Right. And, the underlying core patho is that increased capillary permeability and dead surfactant creating a hyaline membrane.
So for the most dangerous complication, you're watching out for barotrauma from the vent and multi-organ dysfunction syndrome.
And your priority nursing action is instituting that VAP bundle and monitoring hemodynamics when adjusting PEEP.
Which leads to the most important treatment, low tidal volume ventilation and prone positioning.
You got it.
And pattern recognition is key.
Yeah.
If you see a sudden drop in blood pressure and cardiac is increased,
you immediately think decreased venous return from intrathoracic pressure, and you prepare to administer vasopressors while reevaluating those vent settings with the respiratory therapist.
That is exactly how an intensivist connects the physiology to the bedside action.
It's all connected.
It is an intense journey. We've gone from the early subtle warning signs of a struggling respiratory system in ARF all the way to the catastrophic systemic engine fire of ARDS.
Seeing how deeply understanding the cellular mechanics dictates what we do with our hands at the bedside.
So as we wrap up this deep dive, what does this all mean? What is the final takeaway? What is the one thing that often gets lost in all these vent settings and blood gases?
The final takeaway is something you won't find on a ventilator screen, and it isn't measured by an arterial blood gas.
What's that?
It is the profound psychological toll this takes. Patients who actually survive severe ARDS do not just walk out of the ICU and resume their normal lives.
Because of the trauma.
Because of the paralytics, the inflammation, and the prolonged bed rest. They face years of extreme muscle wasting and abnormal lung function. But more than that, they face severe, lasting PTSD from the delirium and the trauma of the ICU experience.
Wow.
The true mark of an elite critical care clinician isn't just knowing how to perfectly titrate PEEP to save the lungs, it is aggressively protecting the human being's mind, their comfort, and their dignity while they lie there, paralyzed and prone, completely dependent on you for their survival.
That is a sobering and vital reality check. The clinical clock is always ticking, but we are treating a human being, not just a physiological machine.
Well said.
Thank you for joining us on this deep dive. Take this intensivist mindset, focus on the mechanisms that matter, and apply it to your next shift or your next exam. We'll see you next time.